Hello and welcome. My name is Elizabeth Wade, and I have shared a short summary of my professional background at the end of these slides. The title of my presentation is Identifying System-Based Causes of Error. This is the relevant financial relationship disclosure for this presentation. This is the learning objective that will be addressed during this presentation. These are the key abbreviations that will be used in this presentation. These are the key definitions that will be used during this presentation. When an error occurs, it is common for team members to want to jump to brainstorming solutions and risk reduction strategies right away to prevent error recurrence. However, when this is done before considering contributing factors in an error, it's common for the actions that are developed to not actually address the medication error at all. So we're first going to take a step back and make sure that whenever an error occurs, we first identify what the contributing factors are. By focusing on each contributing factor one at a time, we can determine whether it's an active or latent failure and develop risk reduction strategies to prevent each type of contributing factor that was actually related to the error. I'm now going to present a case that was reported at a former organization that I worked with. In this case, this was a medication history error, where a patient had a medication history documentation of rivaroxaban 50 milligrams, 50 milligrams on their home medication list. Fortunately, it was a near miss and the patient did not receive this extremely high dose during the course of their admission. But let's start with looking at the case. This patient was transferred from an outside hospital with chest pain. The medication history team obtained the history from the patient. However, the patient was not a good historian, so they relied on outside medical records from the long-term care facility. This patient had a past medical history of AFib and peripheral vascular disease. Now let me introduce a self-assessment question to think about as we talk about this case. Which one of the following risk reduction strategies does not address the dictation error? A. Educate providers that when dictating medication doses for 15 milligram, enunciate 1-5. B. Remove the need to dictate medication lists from the H&P and discharge summary note development process. C. Develop a procedure for medication history technicians to generate lists using the more reliable sources of information first, such as the nursing home MER. Or D. Implement dose range checking or dosing hard stops for rivaroxaban. After we talk about the case, we'll return to this assessment question and provide the answer and discuss the rationale. When this patient first presented to the emergency department, the patient was sent with several medical records. There were medical records from a recent admission from an outside hospital. The history and physical showed that the patient was taking Xarelto 15 milligrams daily. However, the discharge summary from the outside hospital showed that the patient was discharged on Xarelto 50 milligrams at bedtime. Fortunately, we also received the medication administration record from the long-term care facility. The patient is shown here as having received Xarelto 15 milligram tablet, 1 tablet by mouth at bedtime, consistently over the course of the recent few weeks. Upon admission, the admitting provider dictated a history and physical note. Here, the provider enunciated and dictated the Xarelto dose as 15 milligrams, but the transcriptionist heard and documented the note 50 milligrams or 50 on the H&P. This screenshot shows what was documented on the patient's home medication list upon admission to this hospital. You can see that the patient was documented as taking Xarelto 10 milligram tablets, 5 tablets once daily at bedtime. The outside hospital discharge summary that we looked at earlier was the primary reference that the medication history team used to generate this home medication list entry. Fortunately, upon admission, due to the patient's reason for admission, the Xarelto was put on hold during their stay. It wasn't until the patient was getting discharged that this erroneous home medication list entry was discovered. So as we can see, there were several things going on here in terms of errors that occurred. One, we know that the med history technician used an outside hospital discharge summary, but that discharge summary actually contained the incorrect dose. there was conflicting information on the outside hospital history and physical and the medication administration record from the long-term care facility, which were both correct. Further, the second error occurred when the dose of rivaroxaban was documented as 50 milligrams on this admission's history and physical. The doses were dictated as 15 milligram, but the transcriptionist documented and transcribed the dose as 50 milligrams. When we look at this case, there are actually two errors that occurred. One error was that the incorrect dose was listed on the H&P note, and then the second error was that the incorrect dose was also entered on the home medication list, but both occurred for different contributing factors and for different active and latent failures. So let's take the first error. The first error of the incorrect dose being listed on the H&P note was due to a miscommunication in what the admitting provider dictated versus what the transcriptionist heard as the dose for rivaroxaban. The active or latent failure that's underlying that is that verbal dictation of a dose may be unclear. When we look at the second error, this was an incorrect dose also entered on the home medication list. The contributor here was that an outside hospital discharge summary that was used as the primary and only reference was not correct. And the active or latent failure here is that sometimes the references we may use may be incorrect. And so if we rely on a single reference, that may be a single point of failure. So let's come back to our self-assessment question. Which one of the following risk reduction strategies does not address the dictation error? A, educate providers that when dictating medication doses for 15 milligrams, enunciate 1-5. B, remove the need to dictate medication lists at all from the H&P and discharge summary note development process. C, develop a procedure for med history technicians to generate lists using more reliable sources of information first, such as the nursing home MAR. Or D, implement dose range checking or hard stops for rivaroxaban. The correct answer for this question is C. Developing a procedure for med history technicians to generate lists using more reliable sources of information directly addresses the second error in which the medication history list was incorrect. Options A, B, and D are all risk reduction strategies that directly address the first error related to the incorrect dictation and transcription of the rivaroxaban dose on the H&P. Let's take a look at the rationale for each of the risk reduction strategies in the self-assessment question. Providing education to providers when dictating medication doses for 15 addresses best practices for dictation of medication information. By removing the need to dictate medication lists from the H&P and discharge summary note development process, this prevents the need to dictate really critical information about medications that can be complex, such as doses. We talked about the procedure for med history technicians being a standardization strategy for utilizing multiple external sources of medication information to improve reliability, but it does not reduce or prevent the likelihood of a dictation error from reaching the patient. Lastly, if we have dose range checking and dosing hard stops for rivaroxaban, if a dictation error were to recur again, this reduces the likelihood of that incorrect dose from reaching the patient. Part of you may be wondering, where did we come up with all these risk reduction strategies suggestions? Well, one way to address contributing factors is to walk through every step in the medication use process related to that contributing factor. So let's take the dictation contributing factor and the miscommunication issue as an example. In this case, you can see that we've outlined the medication use process that occurs when a provider dictates medication information. After the provider dictates, the transcriptionist documents that medication information. The provider then may reference that medication information to order the medication for the patient. A pharmacist would need to verify that order, dispense the order, and then a nurse would need to administer that medication to the patient. All of these are steps that we should think about when trying to think of risk reduction strategies that ultimately protect the patient. So let's take, for example, the first step in the medication use process here, where the provider dictates medication information. What are some ways we can reduce the risk at this step? Well, by thinking of our top-level strategies and preventing the need to do a step, we could remove the need for a provider to dictate medication lists from the H&P and discharge summary note altogether. Ultimately, the home medication information should come directly from the medical record rather than relying on dictation or transcription. Secondarily, if a provider has no choice but to dictate medication information, we can provide education that when dictating commonly miscommunicated doses such as 15 or 50 milligrams, to enunciate 15 or 50. When we think about the next step where the transcriptionist must document medication information, what can we do to reduce the risk there? A standard guideline or policy for transcriptionists to follow when documenting medication information may be helpful. For example, if a transcriptionist hears a dose of a medication 15 or 50 milligrams that's difficult to understand, a policy could be in place to clarify this with the prescriber. Further down in the medication use process, if the provider were to actually then order this incorrectly dictated dose, there's possibilities with dose range checking or dosing hard stops for rivaroxaban. 50 milligrams or 50 milligrams is not an appropriate dose for this medication. That would be an appropriate risk reduction strategy to help prevent this particular error from going further down the medication use process. To wrap up, it's important to ensure that the risk reduction strategies we put in place actually address the error and its contributing factors at hand. In this presentation, we reviewed a case that had 2 errors and associated contributing factors and active and latent failures. We broke down those errors so that we could look at them separately. For each contributing factor, we evaluated the entire medication use process related to that active and latent failures for risk reduction opportunities. And finally, once you've developed your risk reduction strategies for the error, it's important to conduct a final assessment of the risk reduction strategy to make sure that it addresses the contributing factors that you've outlined. Thank you very much for your time and participation.